This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So I hope you've got a nice little break and can get you recharged for the next kind of sessions. So I'm going to kind of start off the next round of talks, and we're going to shift gears a little bit and start talking about living donors instead. And I think I probably don't need to kind of belabor this point, but basically the number of living donors in the country had basically been declining since about 2004, and there's always a shortage of organs. And the reason why we pursue living donor as an optimal option is because of this particular slide here. You can see that for every single time point, the allograft survival and patient survival tends to beat out deceased donors when you get a living donor kidney transplant. So I wanted to kind of lay the groundwork and let you know, maybe share with you a little bit about what we know about the safety of living donation. So this is basically the data that was up to about 2013. And as it relates to patient survival, there's been a couple of countries that looked at a registry of living donors, and basically it looks like it's a pretty long follow-up, up to about 35 years for each one of them. And not to belabor the point, but if you take a look at the graphs between donors and the general population, and this is, bear in mind, an unselected general population, it looked like for every single one of these studies, the survival between donors and also the general population was equivalent. And the Canadians actually looked at the registry because obviously they've got a single payer system and they've got data on every single person who's donated before. And when you look at the composite outcome of death and also major cardiovascular events, it was donors in general beats out the non-donor general population. And when it comes to major cardiovascular events, there was really no difference between the two groups. So what do we know about the safety of donation as it relates to renal function afterwards? And again, the Canadians have looked at this before, and it looked like on this pooled analysis, there seems to be a general trend that donors tend to result in a slightly lower GFR, which isn't necessarily very surprising. If we all age and we all lose renal function at about the same rate, and you're starting off with a lower rate because, after a unilateral nephrectomy for donation, you're left with about 70 to 80% of your original kidney function. It's probably not a big surprise. And then Ibrahim and his group at the University of Minnesota looked at about a little over 3,500 donors, and there were about 255 of them, and they actually went to the extent of doing an iohexol GFR measurement, so a lot more accurate than your 24-hour urine collection. And they compared it to a group of patients that was extracted from the NHANES database, so the quote-unquote control general population. And as you can see here, there's been a number of end-stage renal disease that happen in donors for a smattering of different causes, and primary of which is, as you expect, unknown. But if you follow the iohexol GFR, it looked like over time, the further out you are, the better the GFR. You ask yourself, that doesn't quite make sense. And I think there's a little bias here because I think the patients who's donated a long time ago probably was a very highly selected group, and we probably weren't as cavalier, or we were a little bit more restrictive with our donor selection, and we selected patients who had higher GFR to begin with, and so it looks like the longer out you are, the better GFR you get. But with the slope of the microalbumin, with time, it looks like the microalbuminuria in donors do show a slight trend for increase. And as you can see here, there seems to be a significant difference between the donor population and the general control population in terms of GFR, and these are the group of patients who donated 20 and plus years before. So that was kind of what we understood, and if anyone's seen this movie, you know that your life's kind of tagging along and status quo, but then something comes along and it kind of completely disrupts that. So what happened was, in quick succession, in 2014, there were 2 studies, one of which, this one was from the Norwegian registry, and it basically looked at about 2,200 previous donors, and again, they've got a single-payer system, so they've got pretty good tracking of all the donors, and then they compared to a control population, which was selected after they've excluded all these chronic conditions that would rule them out for potential living donor, as a living donor, and so there's about 75,000 of them. And surprisingly, if you look at all-cause mortality, it looks like there seems to be a separation. But the important thing that I want to point out here is the separation didn't really happen until you're about 10 to 15 years out. So that might actually explain why previous earlier studies where there was a shorter follow-up, it didn't look like there were any significant difference in terms of the patient survival between the donors and also the general population, because there just wasn't enough time. If you do all these fancy statistical adjustments, even after that, after all the adjustments were made, it looked like the the rates of end-stage renal disease in a previous donor was higher. The hazard ratio here was about 11.4. Obviously, any study has its limitations. This was a very homogeneous population. 100% of them were Caucasian, so I'm not sure that we can necessarily completely translate that into our experience here in the United States, where we're a lot more multiracial. And the one critique that they had was not evident if you didn't read the body of the text, was that the control population was only selected in a particular county in Norway, and it's been well known that the population in that particular county was a lot more healthy in general. And so you may actually sway and bias the results to make it look like the mortality was a lot higher in the donor population. So that's in Norway. What do we know about the donor population here in the United States? So it's Dori Sagev and his group in Hopkins looked at 96,000 patients that were recorded in the SRTR, and they basically looked at the NHANES database again and excluded any patients who had any chronic conditions that would deem them ineligible to be a living donor. And they came up with about 9,000. So there's obviously a huge gap, 96,000 donors and only 9,000 controls. So they used this mathematical manipulation that basically expanded the 9,000 patients so that it's kind of 10 controls to, that same patient gets counted 10 times. And what they found was the cumulative incidence of end-stage renal disease seems to be higher in the living donor population compared to the non-donors, which obviously is of concern. And if you look at the way they stratified it out based on the donor's ethnicity, African Americans seems to have the highest increase in the risk of end-stage renal disease, followed by Hispanic patients, followed by Caucasian patients. So I wanted to kind of put this in perspective, because I think this may actually get lost in the picture. We're talking about an absolute risk increase of 27 over 10,000 patients. So that's about a 0.03% of an increase of risk. Highest, again, in the African-American population and lowest in the Caucasian population. And if you look at the lifetime risk of end-stage renal disease, so you assume that the patient is going to live out to a ripe old age of 80, what are the chances that they're going to develop end-stage renal disease? It looks like the live donors had a higher rate than the healthy non-donors that was very highly selected compared to the patients who were completely non-screened. And that probably points out why the end-stage renal disease rates in donors in previous studies where we were using just general population didn't kind of borne out the fact that there may have been a higher risk of kidney disease. But again, limitations to every single study. I think one of the biggest critique of that particular study was that there was a shortage of controls, and they had to expand the number of a small cohort of controls and counted the same patients multiple times, and that only took a number of very healthy control patients to kind of completely sway the data. And one of the things that I can point out is if you only look at the crude incidence of end-stage renal disease in the donors versus non-donors, so you don't do this mathematical manipulation. It's about 10 per 10,000 for the donors and 18 per 10,000 in the non-donors. But when you do that mathematical manipulation and you take it out to 15 years cumulative risk, it became 30 over 10,000 for the donors and 3.7. So it looked like there was a 10-fold increase. And I think, this is a very illustrative slide. What I tell donors is that there's a minuscule risk, albeit an increased risk compared to if there was a parallel universe and there was another one of them who was an exact clone of themselves, and that person didn't go on to donate a kidney. There may have been a very small increased risk of developing kidney disease in that particular living donor. But taken on the whole, it's still a very, very small risk, and for the amount of good that they can do for somebody else, I still think that that's an acceptable risk to take. So I thought I'd kind of divide the rest of my talk, which can be quite varied, into 3 different broad categories. And I think it may or may not be very evident to you that I think the transplant community as a whole, and certainly in the United States, we're taking on more complex donors. And this particular study, again, from Ibrahim and his group at the University of Minnesota, and in fact, I think there were 3 centers, University of Alabama was also involved in it. And they basically looked at the trends in donor populations over the years, dating from all the way back to 1963 and taking it out to 2008. And you can see here, the first graph on the left-hand side is the donor age. And there's been a slow creep in the number of, in the age of donors that we accept, at least the upper limit of the donors that we accept over time. And also, in terms of the BMI, it looks like there's also a slow creep in the acceptable BMI that we take on. When you look at the systolic blood pressure, there also looks like there's been an increase in the systolic blood pressure on the whole. And that's probably because in the last few years, probably certainly after 1997, about 70% of the hypertensive donors that have donated were accepted after that time period. And if you look at the serum creatinine, surprisingly, we actually have not really pushed the envelope. We have stuck by our guns in terms of what we need as a minimum for the kidney function on the donors before we would accept them as a donor. And the fasting glucose, so these are populations who's maybe got impaired fasting glucose. It looks like there's maybe a slow creep over time as well. And one of the trends that they've noticed is that we're actually a little bit more liberal when it comes to donors who are a little older. So the top graph, or the top Venn diagram up here, relates to donors who are less than 60 years of age. Very small percentage of them have these isolated medical abnormalities, and really only 1% of them have all 3 of obesity, glucose intolerance, and also hypertension, all of which will potentially put them at risk of kidney disease later on after donation. Whereas that number bumps all the way up to about 4% when we are considering donors who are 60 and above. And so that I get this slide out of the way, this is a slide of absolute contraindication for any donors that UNOS and the OPTN have laid the groundwork and said, these are probably not acceptable donors. And it makes our decision easy because these are absolute contraindications. And most of these has to do with uncontrolled, raging infections or malignancies that hadn't been treated yet. Obviously, the HIV part of it, that may be changing in coming years. I was going to move on to whether pre-diabetic donors are acceptable group of patients. I don't want to embarrass my colleague, but I thought, I place credit where it's due. But Sindhu and the group earlier on had looked at about 140 living kidney donors spanning 1994 to 2007 done at UCSF. And about 45 of them were known to have pre-donation impaired fasting glucose. And they also selected a comparable group of patients who were matched as a non-diabetic control. And the mean follow-up of this cohort was about 10 years. And the primary endpoint was the development of overt diabetes in each one of those groups. And a secondary endpoint would be the measurement of MDRD, eGFR, and the degree of albuminuria in this population. And as you can see here, it looked like the number of patients who developed overt diabetes was much higher in those who had impaired fasting glucose pre-donation compared to the control population. And it almost approaches statistical significance. But if you pay attention, the MDRD eGFR at the end of the 10.4 years of follow-up didn't look like there was any difference whether the patient had pre-donation impaired fasting glucose or not. And the same applies to the microalbuminuria, no statistical significance. The group that had impaired fasting glucose, overwhelmingly 60% of them at the time of follow-up actually reverted to having normal fasting glucose. And only a handful of them continued to stay either with impaired fasting glucose or went on to develop overt diabetes. And what is important to note here is on this other slide, is that when you look at all the characteristics that these patients had pre-donation, there's absolutely none of these characteristics that can basically help you sift through and decide which of these impaired or pre-diabetic donors are going to go on to develop full-blown diabetes versus those who are going to revert to having a normal glucose metabolism. Apart from maybe one particular characteristic, they noticed that patients whose impaired fasting glucose that was above 110 milligrams deciliter seems to have maybe a non-statistically significant trend towards developing overt diabetes. So maybe if we had to put our foot down and establish a threshold, 110 may be a number that we should be looking at. And then again, at this group, Ibrahim looked at the number of patients who develop diabetes afterwards versus those who do not develop diabetes afterwards after the donation process. And when you looked at the last eGFR they had, there was actually no difference between the diabetic group versus the non-diabetic group. And that was called in question because earlier animal models showed that having one kidney may actually lead to accelerated renal decline compared to the two-kidney model when you basically make the rats diabetic. But I don't think that necessarily is borne out in human studies. So at UCSF, what we do is we do universal screening, we do a serum fasting glucose on everyone, and then a 75-gram glucose tolerance test. Hemoglobin A1C, when we talked to our endocrinologist, he didn't feel like that should be universally applied because he said that most labs do not have a standardized hemoglobin A1C measurement, and it's prone to error depending on the red blood cell turnaround time. And surprisingly, we actually have the number of patients who actually has hereditary hemoglobinopathies, and that can kind of throw your hemoglobin A1C numbers off a little bit. But it can still be used to kind of settle out certain places where you need a third measurement to kind of draw the line, and it's used at the nephrologist's discretion. When it comes to donors who have gestational diabetes, we have a wait time of about 5 years, and then at the end of the 5 years, they then must undergo an all glucose tolerance test, and that must be normal. And we also put the numbers into a risk calculator, which I'll show you in a little bit. And only if they pass those 2 points will we then accept them. And the risk calculator is up here. I've attached the website, and it's actually quite fun to play around with. I would encourage you to kind of go online through the American Diabetic Association, take a look at it. But there's specific instructions that we tell our patients when it comes to glucose tolerance tests, but I wasn't aware of until I started looking at this when we crafted the diabetic protocol. But they're supposed to eat a balanced diet consisting of at least 150 grams of carbohydrates for about 3 days prior to the testing. And they should not eat, drink, and smoke for at least 8 hours before the testing. And this is the printout of the risk score, and this happens to be my score, and I'm actually fortunate I got a score of 2 out of 10 and deemed low risk. So I'm still eligible as a kidney donor, I hope. And the last thing I wanted to kind of talk to you about is the assessment of GFR and what we use as a criteria for accepting living donors. Basically, what this looks at is this group looked at 365 previous living kidney donors at the Mayo Clinic between 1996 to 2001, and all patients had a pre-donation non-radiolabeled ophthalmic clearance done, which is probably a lot more than most donor centers would do. And the measured creatinine was then compared to the two commonly used methods of estimating GFR, the MDRD equation, which is the fourth variable, the more simplified one, and the Cockhoff growth. And as you can see here, it's, little kind of grim statistics, but, a 20-year-old man has an average GFR, at least in a donor population, of about 129 cc's per minute, corrected for body surface area. And after the age of 20, there's about a decline of about 4 cc's per minute per decade as we age. Whereas with women, you started off as a slightly lower GFR at 20, it's about 123 cc's per minute, and then it also declines a little bit faster after age 20 at about 7.1 cc's per minute per decade as we get older. But basically, the bottom line is there's pretty poor correlation between the estimation calculations compared to the measured ophthalmate GFR. The R-score, which is the statistics for the correlation, was about 0.28 for the MDRD equation, and for the Cockhoff growth, it's probably not that much better. It's about 0.32. To give you a sense, 0 means there's absolutely no correlation whatsoever, and anything that's less than about 0.3 shows a very poor correlation. So what should we do when the calculations that we have can't really be trusted? And the other problem with a 24-hour urine collection is that we used to bang our head against the wall when donors would have to be put through 5 different 24-hour urine collection. Either it's over-collected, under-collected, or they're missing parts of the collection. And so what came to our aid was that we came across the data that cystatin C may actually be a little bit more reliable as a filtration marker. It's been investigated for over 25 years. I think it's it shows better correlation than creatinine with standard measures of GFR. It's less prone to the variations in demographics, gender, race, age, and health status and nutritional status as well. It's not generally generated from muscle mass, and instead, it's actually produced by all nucleated cells and basically gets released in the bloodstream. And it's filtered freely into glomerulus just like creatinine does and metabolized in the proximal tubule. I'm not aware that it gets actively secreted. And basically what Mike Schlipak at the General and his group had looked at with the cystatin C is it looks like overall with the coefficient correlation, there's a little less spread compared to the creatinine, so a little bit more reliable in terms of assessing the kidney function. If you look at these data here, when you classify somebody having CKD based on the creatinine alone calculation, there's probably not a statistically significant prediction value when it comes to all-cause mortality or the prediction of end-stage renal disease. However, when you use the cystatin C as it plugged into the calculation, it looked like there was a statistically significant correlation with both all-cause mortality and end-stage renal disease. And the most impressive of which is if you use the combined calculation using both creatinine and the cystatin C, it looks like a huge correlation with the estimation and the prediction of end-stage renal disease. So these are the various different calculations that they use for using either the cystatin C, the creatinine, or the combination of both. But basically, born out of this data at UCSF, what we've decided on was we still do a 24-hour urine collection for what it's worth, because that's still kind of the basic guidelines that's put out there for the transplant community. And we make an assessment as to whether it's an adequate collection based on these parameters on the creatinine index. And then we plug the information into the MDRD calculation using the cystatin C as well. And that gives us a score as to estimated GFR. And so we get both the 24-hour urine creatinine clearance along with the estimated GFR. And what we usually use as a criteria is any donors who's over the age of 80, we use 80 cc's per minute per 1.73 meters square, and that's pretty much accepted in most of the centers. But we felt that we should be a little bit more cautious with younger donors, and so for those who are less than 30 years of age, we use a cutoff value of 90. And a nuclear medicine GFR, which you may come across because sometimes we ask for this particular test, will come in handy in certain scenarios where there's a discordant result between the creatinine clearance in an adequately collected 24-hour urine collection and the estimated eGFR. So, let's say you get an eGFR of 85, that clearly passes the person for donation, but yet the creatinine clearance in an adequately collected sample was only 65. What do you do in that case? We use the nuclear medicine GFR to kind of settle the difference. And especially in donors who's maybe in that cutoff range of 80 to 90, they don't quite meet our strict criteria, but they may ultimately, the calculation and the urine collection may be grossly underestimating the renal function. We use the nuclear medicine GFR to settle the score there too as well. And the one particular case here is any donors who's got an eGFR of between 80 to 85, who's participating in the National Kidney Registry as the paired exchange, they request that a nuclear medicine GFR be performed, and the nuclear medicine GFR needs to show a GFR of more than 80 before they can pass this patient through. So I hope I've shared with you a little bit of what the thought process that goes into evaluating these living donors. And be prepared, because the size of this guy's cerebral cortex is going to bedazzle you.
Well, thank you, Brian. You're too kind. I somehow think you mixed up the two brains there. But so as Brian outlined, there are rules that we're asked to abide by, made by the OPTN, and he showed you that list of strict contraindications to proceed with donation. But there are many other decision points that we have to make as a transplant center in terms of which type of donors we're willing to accept. And one of the points of contention always comes up about donor weight. The criteria that we've established, which is a BMI less than 35, has really come about after years of gaining more experience doing laparoscopic nephrectomy and getting a little bit more bolder in terms of how large a patient can be to safely get through the operation. Of course, there's the other factor of what is the impact of the obesity on their lifelong health and potential development of later renal disease. So this criteria was really set at our program based on experience, but a lot of these things that I'm going to show you are guided by some principles that were developed at what's known as the Amsterdam Forum, which was a collection of world experts in kidney transplantation to kind of hash out what are the safety limits that should be suggested for donors. And you actually have a copy of that paper in your packet. So a lot of what I'm going to show you actually stems out of that Amsterdam Forum, and it turns out that they set a BMI criteria of less than 35 as well. So at our program, about a quarter of our donors have a BMI greater than 30, which of course is obesity. We are willing to have the surgeon review borderline cases. Of course, BMI is not a perfect measure of obesity, if you will. You may have a very muscular bodybuilder who will be over that BMI criteria, and we're willing to evaluate that patient on a case-by-case basis. And many patients present, of course, with a BMI that's outside of this criteria, and we wouldn't necessarily wait to do any kind of workup or move forward with any of their testing until they absolutely hit that criteria, but they definitely have to show us that they're trending towards that goal. And if you look nationally, this was a study that was done looking at a decade's worth of donors in the US. You can see the range of donor BMIs going from 17 all the way up to 44. The arrow is showing the BMI cutoff at 35. So you can see we're sort of at the tail end of this spread in terms of where we set our criteria. Now, we've looked at our outcomes in obese donors, and this was a study we published probably about 5 years ago now, looking at our initial laparoscopic experience of about 250 cases, and then the subsequent nearly 750 cases, where we started to expand our criteria for who would be an acceptable donor. So we did more right-sided cases, which are technically more challenging. We did more patients with complex anatomy, and we did more obese donors. And if you look at the last column there, you'll see that the obese donor complication rate that we looked at really was no different compared to our smaller, earlier experience. So that was a bit reassuring that even though technically these cases are more difficult to do, we were having equally good outcomes. So I mentioned the other part about the obese donor is their lifelong impact on kidney health. And there are several studies out there that have looked at that, 10 studies that I found looking at obese donors with a mean BMI of 34.5. Only 2 of them really had good long-term follow-up, and it really wasn't even that long-term, in the range of 4 to 6 years. And the impact on later GFR was conflicting between the 2 studies, one showing that there was no difference between obese and non-obese donors in terms of later GFR, and one study showing, the other study actually showing that there was improvement in the obese donors in their GFR over time relative to the non-obese donors. So I think in general we try and promote a healthy lifestyle in these folks, and hopefully with close follow-up they'll adhere to that. And these studies also really didn't see any significant difference in blood pressure change. Now, smoking is another area where we often have arguments about what is the right thing to do. Generally, our rationale for cessation smoking recommendations is extrapolated from findings in other studies looking at other types of non-cardiac surgery. It's very clear that there's an increased risk of pneumonia, deep vein thrombosis, and wound healing problems when you look at some of these other studies. And clearly, withholding cigarette smoking for 4 weeks before the procedure does have an impact on these complications. So our current protocol actually asks for 6 weeks of smoking cessation, and we include all inhaled tobacco products, so inhaled marijuana is asked to be held for 6 weeks as well prior to the donation event. Patients can go through their workup if they're still smoking, but it's a very rigid requirement that they stop inhaled tobacco products 6 weeks before surgery. And there's been a study that looks specifically at donors and the impact of smoking on potential complications. And interestingly, they didn't see a difference. The smoking donor and the non-smoking donor really didn't have a statistically different outcome in terms of the complications shown here. But interestingly, and maybe not too surprising, is the recipient survival in terms of the kidney transplant recipient was actually worse if the kidney came from a smoking donor, which again may not be too surprising. So one way to kind of sell this to the donors, I guess, is to say if you really want to take good care of yourself and improve your recipient's outcome, think about giving up those cigarettes. What about kidney stones? This is a very common problem, either through the history of the donor, having had stones in the past, or more commonly, as we now use more detailed CT angiograms that can pick up the very smallest of calcium deposits in kidneys, we have a lot of patients who are labeled as patients with kidney stones. And our criteria are basically they can be an acceptable donor if they have a single stone and they haven't had any active stone disease for greater than 10 years, so if they passed a stone in the distant past. If we do find one on our final study, the CT angiogram, and they go through the metabolic workup and that's negative, it's okay for them to proceed. And of course, the cardinal rule is we would remove the kidney with the stone for transplant. And again, we'll only think about accepting donors in this situation who have a low risk of kidney stone formation based on their urine metabolic and serum profiles. So the unacceptable donors are patients who have known cystine or struvite stones because of the high risk of recurrence. Certainly nephrocalcinosis is an absolute rule out, hyperparathyroidism, inflammatory bowel disease. Again, you don't see many donors with that history. Certainly primary and secondary hyperoxaluria would be a rule out as well. And then per UNOS guidelines, bilateral stones is an absolute rule out. So in terms of evaluation, we'll certainly start with a renal ultrasound if they've had a past history of stones, because if they have bilateral stones on their renal ultrasound, we would stop the workup at that point. And then as I mentioned, we do put them through a detailed urine collection as well as some serum tests to see what their risk is for future stone formation, and if they are in the low risk category based on that profile and then meet the other criteria, they can move forward. So there are some gray areas. What about the age cutoff? We currently use donors only over the age of 40 if there's a history of stone disease. There are other programs that don't really have an age cutoff, so that's something we've been talking about. If they have a borderline metabolic workup, maybe with some lifestyle adjustments in terms of their diet, how well they hydrate themselves, maybe it's still safe to proceed. And we have used a couple of donors that have been carefully counseled in that regard. What about family history? We're currently doing metabolic workup in patients who have a strong family history of stone disease. Generally, we'll rule out patients who have had a formal gastric bypass because of the high risk of future stone formation, but if they've had a sleeve gastrectomy and have a negative metabolic workup, they could still be an acceptable donor. In terms of donor malignancy, another thing that comes up fairly frequently, again, we are guided by national policy, and it basically says that the donor workup should include a thorough review to look for any evidence of malignancy, and specifically the rules say we should look for cervical cancer, breast cancer, prostate, colon cancer, and lung cancer using current cancer screening guidelines. The absolute rule outs would be a donor who has melanoma, testicular cancer, cholangiocarcinoma, any hematologic malignancies, or breast cancer. However, a prior history of a malignancy may be acceptable if several criteria are cleared. One is that the prior treatment should not have impacted their renal function or place them at future risk of deteriorating renal function. The prior treatment should not affect the planned operative site, so if they had major radiation, for instance, on the side of the planned kidney removal, that's not an acceptable situation. And then patients who have had a cancer in the past that has a low chance of recurrence, in other words, they're technically cured, may be acceptable as well. So examples would be carcinoma in situ of cervix, non-melanoma skin cancer, and then an early stage colon cancer with a good long-term disease-free interval follow-up. There is a special situation of renal cell cancer, and again, this doesn't come up much in our living donor program, but certainly there have been cases where early stage exophytic tumors that are identified on a potentially transplantable kidney can be excised and then transplanted into a patient who, of course, has proper informed consent. The follow-up imaging of the recipient is important, and in case reports where there has been metastatic disease from a transplanted kidney of this type, or where a tumor wasn't recognized and transplanted, you can actually have rejection of the tumor if you withdraw the patient's immunosuppression. So we have had a couple of rare cases where our urology colleagues have told us they have a patient with this type of tumor, early stage exophytic tumor. The patient has decided not to undergo salvage therapy of their own kidney. They just want it removed, and they'll call us and we'll review the case and potentially can use that kidney after excising the tumor, confirming the pathology of the margins is clear, and then of course use it in a patient generally who's a little bit more desperate, with a predicted higher rate of trouble on dialysis with informed consent. And in the couple cases we've done, it's worked out very well. What about donor infectious disease? Again, we're mandated to check for this laundry list of different infections. Syphilis testing, TB is done only if the patient's from an endemic area. Other endemic diseases to consider are coccidio, cocci, strongyloides, Chagas disease, and West Nile virus. We do sometimes have patients who are hepatitis B core antibody positive, and in that situation, we'll usually try and immunize the recipient if time will allow. We certainly want to know if the donor has active circulating virus, so we'll do a viral load, and then the recipient is prophylaxed. But this type of donor can serve as a kidney donor. And we've heard earlier about HIV. We have not yet embarked on using a living donor with HIV who would donate their kidney to a recipient with HIV, obviously because of the concern about the donor's future safety and development of HIV nephropathy. And it may very well be that the HIV pool of positive HIV donor kidneys may be adequate to serve the recipients who have HIV, so we may not need to pursue living donors in the future, although people have talked about maybe being able to stratify the risk for a potential HIV positive donor of giving their kidney, much the way we do with diabetes in potential donors. And the Zika virus, the new infection on the block, again, the transplant community is sort of wrestling with how to deal with this, but basically the current recommendations are that if a patient has traveled to an endemic area, that they don't donate for 28 days after their travel. So the last area I want to cover is just some complex anatomy issues. When will they rule out a donor? Well, as you all know, we have to do imaging to make sure a patient has 2 kidneys. If they have 1 kidney, they're definitely ruled out. All characteristics being equal, we usually like to choose the left kidney because it has a little bit longer vein, renal vein, makes the transplant a bit easier to do. But the cardinal rule is we like to leave the donor with the more perfect kidney. So if there's 1 kidney that's a little bit smaller, that's the one that the recipient will get. If there's 1 kidney that has a big cyst, that's going to be removed and the donor will be left with the kidney without the cyst. We deal all the time with multiple arteries, multiple veins, multiple ureters. Rarely is that a contraindication to move forward. Of course, there is always the issue of polycystic kidney disease and family history, and we'll do the genetic testing of potential donors to make sure they're not at risk for developing that in the future. So just a couple quick examples here. This is an angiogram of a patient that had 3 arteries on the right and just a single artery on the left, but it turns out they had 3 veins on the left. Much easier to deal with multiple arteries than veins. Some centers might turn this donor down. We are happy to put the 3 arteries together. This is the backbench work after the kidney's been removed. You can see the 3 arteries joined together, and I don't know how well it projects, but you can see the kidney after it's been reperfused. So this is something we probably deal with about 20% of the time, multiple vessels. Other techniques would be to take the 2 arteries and put them into a patch of deceased donor vessel that we might have in our vessel bank, and that makes it a little bit easier then to sew it in the recipient if you do this reconstruction on the back bench. We have had donors who have had renal artery aneurysms, and again, we'll take that kidney, and then on the back bench, we can resect the aneurysm. And this is one of those examples of a case where a donor really gains some benefit by having gone through this workup, because now they've had this disease, this kidney, which might have caused them problems in the future, removed, and at the same time, it's a very transplantable kidney that can be used in a recipient. The one situation that we wouldn't do is a horseshoe kidney. This has come up a couple of times on the final stages of workup as the patient has their imaging. The anatomy is just a little too complex to deal with in the living donor situation, although certainly we've used deceased donor horseshoe kidneys where they can be divided into two usable kidneys. Fibromuscular dysplasia is a problem that we used to see a lot more when I started, when we did conventional angiograms. And whether it's the resolution of current CTs or some false positives because of spasm caused by the angiogram catheter, I don't know, but we're certainly seeing a lot less of this with our CT angiograms. But occasionally we'll find it, and presumably it's a little bit more extensive disease. If there's any question about it, we'll confirm it with a conventional angiogram, but if it's unilateral disease, and again with informed consent of the donor about future risk of progression of disease, and in donors over age 50, we will consider them for donation, again removing the involved kidney. It'll sometimes require reconstruction of the artery in the recipient, and again the donor needs to be watched very closely for future signs of hypertension. And this is just an example in the bottom frame. You can see what we used to see, not uncommonly when we did conventional angiograms, the beaded appearance of the renal artery. Now, Brian mentioned earlier the risks of donors developing later end-stage renal disease, which fortunately is a very rare event. If you look at our experience since the 60s, when living donors had been done at UCSF, we've had about 10 donors go on to develop end-stage renal disease, so it works out to about 1 in 3,000, which Dr. Segev's study would have predicted would be our rate. I don't know how many of you know that the current allocation policy actually gives very high priority to previous kidney donors who go on to develop end-stage renal disease, so they get very high positioning on the list just below those highly sensitized patients for a deceased donor kidney. And when this access to transplant and eventual outcomes of transplant has been looked at, it turns out that donors who get this priority listing end up waiting a median time of about 100 days. But unfortunately, you would hope that these patients would be transplanted preemptively and never have to have dialysis. And that only happens about 30% of the time, which again sort of emphasizes the importance of yearly follow-up of these donors and referral to a nephrologist if there's any signs of deteriorating renal function. So in conclusion, Brian and I just want to make it clear that balancing donor safety with the need for doing more transplants is critically important. Certainly the modifiable risk factors, some of which I reviewed here, should ideally be addressed and corrected in an effort to improve the safety of the process. We do have hard stop exclusion criteria that we can't budge on that are dictated by OPTN policies, but we wrestle all the time with some of the other transplant center policies that we can adjust depending on what our current risk-benefit acceptance seems to be. So, thank you.
Questions?
Yeah.
Question for Brian.
Oh, good.
Based on the data you reviewed, what is the standard follow-up you would recommend for the donor?
So basically what we do now is after they get discharged from the hospital, we have at least one visit that takes place anywhere between day 7 to 10, and they come in along with the recipient, where we actually, the team meets with the donor. After which, basically what the UNOS have mandated is that we get long-term follow-up on these donors in the sense that they get laboratory values, blood tests, and also urinary studies that, that we are supposed, what we pay for. And we actually direct them to a nearby lab that's close to their home. And these labs get done at month 6, 1 year, and 2 years. That's kind of the mandate right now. We also offer to them that if there's ever an issue, that's, you know, related to donation itself, we'd be happy to see them and deal with whatever problem that's arisen. I don't want to say it's a lifetime guarantee, but, you know, we've never turned any donors down. If there's ever an issue, we welcome them in with open arms. But basically, most of the donors go on to, you know, they're healthy, they continue to be healthy afterwards, they follow up with their primary care, and we get those laboratory values at those time frames, but we may not necessarily see them again.
But we would recommend yearly follow-up for life. I mean, we tell all donors that. Okay, thank you.
Thank you.